It's one of the slides that you had yesterday, but I'll use this slide just to remind you the differential diagnosis.
Lymphoid tissue.
It's a lymphoid tissue. It's a lymph node. You can see the capsule, and you can see the lymphoid follicles. Some are with primary form, some like this in the center are activated. So you have the pale germinal center there. This is the normal architecture of a lymph node. And you have, in fact, two lymph nodes. One of the lymph nodes to diagnose is this lymph node that you had yesterday, where you can see that there is metastasis with these malignant cells forming glandular tubular structures. And you have this fibrous reaction, which is known as the desmoplastic reaction around the tumor cells, and this metastasis affects also the surrounding fat tissue. So when you recognize the lymphoid tissue, you have to make differential diagnosis between the two lymph nodes. One is metastasis, like this one, and the other lymph node is with Hodgkin's lymphoma. In the Hodgkin's lymphoma, you have the whole structure of the lymph node is effaced by proliferation of different type of cells that we are going to discuss. But you cannot easily find where were the normal follicles. You have large bands of fibrosis here within this slide. And when you go on high magnification, you can see different type of cells. It's good for the lymph node to use the highest magnification. So, what are the cells that we see now? Can you try to describe them? I'll stop somewhere. I just want to find a good area for that. Okay, this is good. So, what are the cells that we see? Alexandra, can you try?
So we see many lymphocytes.
Okay. How will you recognize the lymphocytes?
So they're more like purple, darker color. They are very like multiple on this slide. Also, they are round and
dark stained.
Yeah, dark stained.
And they have almost no cytoplasm visible because the size of the nucleus is the size of the cell. Okay, so we have a background of inflammatory cells. We have a lot of lymphocytes. We have macrophages. How we recognize the macrophages? They have more vesicular nuclei, and sometimes you can see a lot of things, phagocytosed in their cytoplasm. We have also fibroblasts that formed this collagen. You can see here in the right part of the screen. Is it right part on your microscopes, on your screens? And you can see a lot of eosinophil leukocytes here. Do you see them? Or should I put them in the center? Do you see how many eosinophil leukocytes you have?
Yes.
Okay. So we have the background of inflammations. Plasma cells can also be found, but because I cannot use the arrow, even if I use it, you don't see it. It's a little bit difficult. But beside these cells, we have a very interesting cells. I'll put two of them in the center. And do you see this lacuna is the term, so they are called lacunar cells. One in the center, it's B nucleated. Do you see this cell? With red
Yes.
nucleolus. Okay. It is in the center. It looks like mirror image. You agree? This is a typical Reed-Sternberg cell. When we find this Reed-Sternberg cell or RS cell with the vesicular nucleus, with the nucleolus almost the size of a lymphocyte, usually red stained, in a lacuna, then and the background is of matured lymphocytes and inflammatory infiltrate, plasma cells, macrophages, fibroblasts, then we can make the diagnosis of Hodgkin lymphoma. And there is another cell that I'll put here in the center, which is multinucleated, and it looks that the nuclei overlap to each other. I can't count them exactly how much they are, probably more than 6. It is another typical RS cell, Reed-Sternberg cell. And it's easy to find these cells. Another one I'll put again in the center with the red nucleolus, probably 3 nuclei, but just one nucleolus is seen on the cell which is above the others, again in the lacuna. This is the specific morphology for Hodgkin's lymphoma. But as we have discussed, to diagnose Hodgkin lymphoma, you should have the background of matured cells that are specific for the inflammation. You should not have atypical cells in the background, because these RS cells can be found also in some T cell lymphomas or B cell lymphomas. So to diagnose Hodgkin lymphoma, we need background of inflammation. And that's why I really recommend to my students not to make cytology, aspiration biopsy for enlarged lymph node if you don't know what you're looking for. For example, if you have a patient with melanoma malignum and he was diagnosed and you have relapse of the disease and you're sure that you have metastasis in the lymph node, then you can just confirm with cytology. But if you have no idea why the lymph node is enlarged, then take a biopsy. Because if you just take the cells during the aspiration and you have no Reed-Sternberg cells in your cytology specimen, then you'll find just the cells of inflammation, and your patient will not receive on time the diagnosis, which will be very pity, because Hodgkin lymphoma usually starts from one group of lymph nodes, usually in the neck region, and then knowing the anatomy of the body spreads to the other groups, and further on, it starting from the neck, later on it will affect the mediastinum, then it will cross the diaphragm, it can affect the spleen, the retroperitoneal lymph nodes, and then you'll have infiltrates from the lymphoma in the other organs. So not to miss a diagnosis, the best approach to diagnose a lymphoma, which is primary neoplasm occurring in a lymph node, is to make excision biopsy. Remove the whole lymph node and send it to the pathology department. Okay? So, discussing Hodgkin lymphoma, you have classical Hodgkin lymphoma, like this slide, and there are 4 types of Hodgkin lymphoma. Can you say which are these forms? Do you know them?
We have nodular sclerosis,
Okay. To diagnose a nodular sclerosis, you need these lacunar cells. Lacuna from this empty space around the rich Sternberg cells formed during the processing of the tissue. And this is an artifact. And together with the fibrous bands that were seen at the beginning, I now use slow magnification just to demonstrate. Here, for example, there is fibrous band with connective tissue and collagen. We can diagnose nodular sclerosis. It's one of the forms with good prognosis. It can start either from the neck region or from the mediastinum. Some of these will start from the mediastinum, which is the most, the age affected by the Hodgkin lymphoma.
What?
What is the age of the patient?
32 years old is the average.
But it has also two peaks.
It has two peaks, I agree.
In earlier life and after 50s.
Okay, that's true. And the other form of Hodgkin lymphoma, which is in your slides, is mixed cellularity. I don't know whether they've given me such a slide, but we'll see. You have no fibrous bands, but too many eosinophils. Let me just focus. There's fibrosis here. It's again nodular sclerosis. But in the nodular sclerosis, it's more easy to find the rich Sternberg cells because they stay in empty spaces like lacunar cells. And so we have nodular sclerosis, mixed cellularity. Which are the other forms?
Lymphocyte rich.
Yes.
Lymphocyte depletion.
These are the four types of classic type of Hodgkin lymphoma. And we have also the lymphocyte predominant form that where the rich Sternberg cells, they are called Hodgkin cells. They look like popcorns because of the invaginations of the nuclear membrane. Okay. Nowadays, we prefer to have evidence-based diagnosis for Hodgkin lymphoma, and most of the lymphomas are typicized by using immunohistochemistry. And rich Sternberg cells, which are of B cell origin, they're negative for CD20, but they're positive for CD15 and CD30. And also their new PAX can be used, PAX5. And that's how we diagnose this. Most of the T cells are, in fact, most of the lymphocytes are, in fact, T cells. Here again to see the background of inflammatory cells. And it really takes time. I agree that when you're in stress, you can have problems, but you have just two specimens from a lymph node. One is with Hodgkin lymphoma, and the other is from metastasis. So I don't think you have a problem to diagnose this. Do you have questions for the Hodgkin's lymphoma?
Doctor, can Hodgkin lymphoma also be associated with the HIV?
Yes, it can be associated with HIV infection, if this is your question. And it depends on the symptoms, whether it will be AIDS. But it is not so common like large B-cell lymphomas that are more common for the HIV patients, including those that are with extranodular region. They usually start from the lymph nodes. So to be aware of the terminology, lymphoma usually starts from the lymph nodes, and this is neoplastic proliferation of the neoplastic cells. And then we'll discuss the classification of lymphomas next year. So now we expect from you to be aware absolutely with the Hodgkin lymphoma. But what does it mean, leukemia, then?
There is high presence of white blood cells, undifferentiated white blood cells in the blood. It's a type of blood cancer, leukemia.
So where these cells will be formed?
In the bone marrow.
In the bone marrow. But because you know that the lymphocytes, they are able to migrate to home in some lymph node, so to preserve their function, then they can move to other places, including bone marrow. And this has an impact on the stage of the lymphoma if they are found in the bone marrow. And being in the bone marrow, they can enter the blood. It is not common for Hodgkin lymphomas, but for most of the lymphomas, we can find sometimes the lymphoblastic or lymphocytic, depends on the type, the cells in the blood. So this is known as leukemization. For the true leukemia, like CLL, you have the formation and the start of the process from the bone marrow, and you can find these cells normally in the blood when you examine the smear, for example, or if you do immunophenotyping of the blood. Or it's interesting, for example, that the next topic we are going to discuss, which is the chronic lymphocytic leukemia, which is common disorder. And you have absolutely looking mature cells, so we should have an aberrant expression, abnormal expression of these lymphocytes with immunohistochemistry or with flow cytometry on the blood sample. And there are typical Gumprecht's shadows that they produce on the blood smear when it's tested under the microscope. But these cells, they look mature, as you can see here. And we call this chronic lymphocytic leukemia. But sometimes we have a patient with the same infiltrate effacing the normal architecture of the lymph node within the lymph nodes, and then with the same genetic alteration, and then we call it small lymphocytic lymphoma if the bone marrow is not affected. The demonstration for CLL, chronic lymphocytic leukemia, for your slides is in the liver tissue. The typical place where these infiltrates will be found. Do you see these lymphocytes? They look absolutely matured lymphocytes. Without immunohistochemistry, they do not look, will not find that they have proliferation for its own, and the morphology is still preserved. These are the naive lymphocytes. And now how to diagnose this slide? Because you have two examples of leukemia in the liver. Just to the focus to come. What is typical from the chronic lymphocytic leukemia is that the leukemic infiltrates are predominantly concentrated in the portal tract. Do you see this? Within the central vein, around in the liver tissue, in the sinusoids, you'll find almost no infiltrates from the leukemia. Okay? So when you find the leukemic infiltrates predominantly located in the portal tracts, then you can diagnose CLL. So starting with the low magnification, this is your approach. you look that you have these blue areas because of the busy hypercellularity of lymphocytes. Then you go on the further magnification to see what type of cells you have there, and you'll find a lot of lymphocytes. Sometimes you can find paraimmunoblasts, but I can't point them because you don't see the pointer. Anyway, I think it's not difficult for you to diagnose this slide. And in general, what will be the problems of the patients with CLL? What do you expect to find? How you diagnose in the clinic when you suspect? We don't do biopsy from the liver to diagnose. How we suspect CLL diagnosis?
The immune system of the patient will be affected most by this leukemia. So we can find high susceptibility to infections. Also
what type of infections?
Bacterial infection, mostly.
Okay.
And
so
also
bacterial infection, the problem with the infection is that you have a replacement of the normal hematopoiesis in the bone marrow. And particularly for the patients with CLL, bacterial infection, it's not like acute leukemia where you have ulceronecrotic changes in the oral cavity, for example, or you have severe bacterial pneumonia with abscess formation. It's more common in acute. This is chronic leukemia. So we expect to be more slowly progressive. And they are at risk for pneumonia, and some of them will die from pneumonia, but it is usually interstitial pneumonia in the lung caused by mycoplasma pneumonia. Okay, so you have a specific cause. It's interstitial pneumonia, and really, but because of the replacement of the bone marrow, normal myelopoiesis in the bone marrow, most of the patients will have anemia.
Hemolytic anemia, yeah.
It can be hemolytic, but even without hemolysis, most of the patients will have some, and because these are not young patients, they can have underlying ischemic heart disease. So the anemia will worsen the symptoms of ischemic heart disease. Fatigue will occur more commonly in these patients. And when you have such a patient that have fatigue, worsening of the symptoms of ischemic heart disease, and you find the anemia, for example, in the blood test, from the examination, what you'll find?
Hepatosplenomegaly or just hepatomegaly, and also if there is infiltration in the lymph nodes, they will be enlarged and painless.
Exactly. Hepatosplenomegaly is very important sign that you should continue the test and make a blood smear to see the morphology of the lymphocytes. You'll find that there is usually lymphocytosis. You can do immunophenotyping. And the hepatosplenomegaly occurs because of these infiltrates that now we are seeing in the liver tissue, but the same can occur also in the spleen. And in patients with CLL, and in general, in non-Hodgkin lymphomas, you have generalized lymphadenopathy. That means that it's different from Hodgkin lymphoma. Hodgkin lymphoma starts from one lymph node and affects the whole group. In non-Hodgkin lymphoma, all groups you have enlargement of the lymph nodes. This is very important. It's absolutely true for the patients with CLL, so it is really very important finding. So you can do immunophenotyping for this, or on the smear. These lymphocytes have bad preserved membranes, so Gulbrecht shadows. This is what you'll study in your hematology course, will be seen on the smear, and it is really very, very specific. Okay, do you have questions for the CLL, how to diagnose this? My experience is that when you have a liver tissue for the exam, you're concentrated on the primary tumors. You usually do not miss hemangioma cavernosum hepatis, but you always think of, for unknown reason, for hepatocellular carcinoma. And I want to focus once again. We'll go on a lower magnification, look that the normal architecture of the lobes is preserved. The hepatocytes have no polymorphism of the cells. There are other students that want to join. There can be some degenerative changes. For example, I don't know what is the age of this patient, but just to remind you that you can always find something more than you expect. In the center, I have put a central vein. And look in the lower part, the hepatocytes, they have a golden yellow pigment. What was that? Known also as pigment of aging.
Fuscin, lipofuscin.
Exactly. This is lipofuscin. If you put this, the same slide on polarized light, it has the property of autofluorescence, so you can diagnose. And discussing in general, there are other interesting things that sometimes can occur. For example, if you have at portum hepatis enlargement of the lymph nodes, it can cause obstruction of the bile ducts, and signs like jaundice will occur. And you can see here that, not in this slide, but in general, discussing possible complications, the bile ducts will be filled with bile. It's not in, again, to say within this slide. Here is the bile duct in the portal tract. Do you see in the center a small bile duct with very nice epithelial cells forming a lumen? Do you see it?
Yes.
Okay. So this is for the diagnosis of CLL. Do you have questions for this slide? And last but not least is to discuss on chronic myogenic leukemia. What do you know about CML? Shazam, you've joined just. What do you know about CML, chronic myogenic leukemia?
Chronic myeloid leukemia. It can occur due to the Philadelphia chromosome.
Okay. And this finding for Philadelphia chromosome made the revolution for our understanding not only of hematology and neoplasia, but also for solid tumors. And nowadays, most of the classifications were reviewed from the experts in the world to join to the histology and to the morphology, the specific genetic alterations. Some of them can be used as targets for therapy. And this is the revolution of the treatment and the basic for the personalized medicine. So that's why the Philadelphia chromosome is important not only to diagnose chronic myogenic leukemia, but it has a very important historical part that it was admitted and used in other fields of the tumor knowledge in nowadays, okay? So what is the Philadelphia chromosome?
It's a
And what-
chromosome 922 translocation.
And how it changed the normal background in the bone marrow.
Doesn't it cause increased growth because of the BCR-ABL fusion gene, and it causes increased growth and proliferation?
This is the problem with most of the neoplasia. You have proliferation that is not adaptive. It is for its own. And what will be the symptoms of chronic myogenic leukemia?
The onset of the disease is very insidious because we can have anemia and hypermetabolism due to the cell turnover, the high cell turnover. Then, of course, we have weakness, weight loss, anorexia, and sometimes we can have also pain in the abdomen due to spleen enlargement or to also lead to spleen infarction in the first time.
Okay. Nowadays, the chronic myogenic leukemia is in the group of myeloproliferative neoplasms, and we'll discuss this group next year. And we have a target therapy for these patients. And with the progression of the disease, some of them can turn in with accumulation of additional genetic alteration. This chronic myogenic leukemia can turn in acute myeloblastic leukemia. It's important. So, going further, what is on we see on histology? Do you see the difference in the infiltrates comparing with the previous slide? Where are the infiltrates found in chronic myogenic leukemia?
Also in sinusoids.
Yes, they're not in the portal tracts. They are between the tubercles of the hepatocytes. Even some of the hepatocytes look like with some degree of atrophy. They are difficult to find. So, in the chronic myogenic leukemia, they adapt. They try to infiltrate in all organs that they have the same sinusoid structure of the normal bone marrow, and in the organs that there was a previous hemopoiesis during the embryonic development, for example. Okay, and now, and beside the location, then the next step is to see what is the type of these infiltrates to be absolutely sure. And comparing with the lymphocytic leukemia, you can see that in the infiltrates within the sinusoids, there is a tendency for segmentation of the nuclei, which is important. So there is some cytoplasm, there are some granules, so you can easily diagnose chronic myogenic leukemia for this liver tissue. I don't think that it is a problem. And do you know why Virchow called this disease leukemia? What you'll find in the blood test?
Increased white blood cells.
Increased in what extent? So that during autopsy, because of the very, very high number of leukocytes, the blood clots look white in color. And that's why the blood look white.
Doctor, is it true like 100,000 cells per cubic millimeter of blood?
Yes, it can be, but some patients with leukemia will have a normal count, and some can even have lower. So you should see the morphology. What is interesting in these blood smears is that taking blood, you can see all maturations forms of myelopoiesis, so it resembles what we normally found in the bone marrow. What about the tendency of hemorrhagic diathesis? It is something that we did not discuss, but it is beside the anemia, beside the risk of infections. These are the complications of all leukemias in general. Because of the replacement of the normal myelopoiesis, you have anemia, you have risk of infections. If you have high number of blood cells in the blood, it will change the rheologic properties and can increase the risk for thrombus formation and respectively thromboembolic complications. But it's important that usually first symptoms are because of the low number of thrombocytes. Do not forget this. Many of the patients will have complaint for hemorrhages in minimal trauma. For example, they will have bleeding from the gingiva in the oral cavity during tooth brushing. Or they can have petechial hemorrhages on the skin that are visible. So the tendency for bleeding is important for these patients. Okay, these are the 3 slides for hematology. And because we had 2 exercises today, and I see that there are few people, in fact, you're just 1/2 of the people that are expected to join our exercise, if we can say so. I think that it will be really very useful if you send me an email with a classification of the soft tissue tumors for tomorrow. And what time will start tomorrow?
At 11 o'clock.
11 o'clock, okay. So I can use these emails as attendance to the lessons, if you don't mind. Are there students that do not know our meeting? Don't have any idea? Have you sent the connection to your groups?
Yes, we have. We have sent the email, but we don't know if someone doesn't know.
Okay, so tomorrow we have to discuss the tumors of the nervous system. It will be good approach if you read the general part for the tumors of the nervous system. And of course, we'll review all your slides that you think you have problems if you have to diagnose them. You had about 2 months to review the slides your own. Now you have these virtual exercises. So I will really like if it is more interactive. So you really train yourself in description. So if you have some problems with the slides, it will be very good tomorrow when we start to tell me so we can discuss. Okay?
Okay.
So
excuse me, Professor.
Yes?
What kind of classification you asked us to prepare?
Well, I asked you in the first part of the exercise when we discussed the mesenchymal tumors, that
Yes.
it will be useful for you to make a classification according to the type of origin of what type of mesenchymal tissue the tumor originates. This should be the first column. And the second column will be the terms for benign tumors, the second, the third intermediate, and the fourth malignant tumors. And for example, for the fibrous connective tissue, that what we will discuss, you have the benign fibroma, intermediate fibromatosis and desmoid tumor, and malignant fibrosarcoma. And it will be useful because you can organize your knowledge. I think it's very important. And send me to the email of Medical University MU pathology.
Doctor, sorry, I had the problem with connection. Do we have to send you an email with the classification made by?
Yeah, just the table. You make the table, you make a copy on your phone and you send me. Or if you do it on your computer, you can send me as a Word file. And
Okay.
we'll see what you have missed from the classification. I'll leave a few minutes to discuss on it tomorrow.
Okay.
And what's the email you said?
The email is of the medical university in the pathology, the same email that we are now.
Okay. And about the attendance,
You can
said.
address it to me. You can write to Vlahova, for example, when you send the email.
Okay, and what did you say about the attendance?
I can use it if somebody asks me for the attendance. I'll use your emails that you've joined this, because I think that all of you that were on the exercise today will send me an email.
Yeah. All right. Thank you.
You're welcome. Thank you for the attendance. See you tomorrow, 11 o'clock. Bye.
See you. Bye-bye.
Thank you, bye.
Thank you.
Bye.
Goodbye.
Bye-bye.